We're going to switch gears now and talk about perioperative considerations regarding neurosurgery. First up is talking about diagnostic procedures. There's obviously the history and physical performed by the physician. In addition to that are MRIs and CT scans. PET scans are pretty popular because they show the physician a 3D image, and EEGs, which stand for electroencephalogram, are great because they measure the electrical activity of the brain before a procedure. Peripheral nerve studies include electromyography, which measures the conduction rate of motor nerves, and a somatosensory evoked potentials test measures sensory impulses from the body to the brain. One major consideration that we must always remember is the real-life fear our patients may be experiencing regarding neurosurgery. The brain and spinal cord are so vital to our livelihood. It's very reasonable to be afraid they may not wake up, or may lose eyesight, or may not have motor function restored. Every part of brain and spinal cord serve a purpose, and I know I say it all the time, but our patients just don't come to us when they're well. They're sick, and they want to be better. But it's not unreasonable for them to be fearful of whether that's a real possibility or not. We must remember they are highly aware of their surroundings, even when they appear like they're not, and they need our emotional and psychological support to get through these procedures safely and successfully. The operating room that is set up for neurosurgical procedures requires quite a lot of stuff. First, there's the OR bed with the appropriate positioning equipment. They may need to be in lateral, prone, or supine for spinal surgery, and the same goes for brain surgery depending on the area that needs accessed. The patient must be carefully positioned to protect their joints, peripheral nerves, genitals when in prone, and be secure so the surgical team can perform their surgery without the patient moving even an inch. There will be a Bovie machine. There's usually a bipolar machine as well. There's often a nitrogen tank or nitrogen line for saws and burrs. They often take radiographs or use a C-arm to ensure that they're working in the right area of the brain or spinal level. Neurosurgeons often employ the use of the microscope as well. Sometimes we need quite a lot of instruments to achieve the goals we've set, like in spinal fusions, and they'll use a Mayfield table instead of a Mayo because it's larger and can still be positioned over the patient if draped properly. Here you see a picture of head positioning equipment often used for cranial and cervical surgery. The one on the left uses pins to secure the skull in the frame, and the other uses the head to rest on the padded rests. The one with the pins ensures the patient's head will not deviate from its position, so you often see it used when performing brain surgery, while the other is more friendly and is often used on occipital or posterior cervical cases when deep flexion is required, but rotation is not. Here you see two options for spinal surgery positioning equipment. There are quite a lot of methods out there to position a patient. I personally have worked with 7 different neurosurgeons, and all of them have their own specific method. Another cool table is the Jackson table. If you Google Jackson table images and see patients on a bed, can be utilized to rotate the patient intraoperatively without taking them off of it. This is extremely helpful in anterior-posterior spinal fusion procedures where they fuse the spine from the ventral and dorsal sides. I mentioned much earlier how many of these procedures require the use of orthopedic instrumentation due to the structures being surrounded or protected by bony tissue. You'll have sets that have general instrumentation like scissors and needle holders, forceps, Kellys, and so on. But you're also going to see specialty instruments like Kerrisons and rongeurs, neuro retractors, and nerve root instrumentation. There's also the need for microsurgical instrumentation too. So make sure you look through that neuro section in your instrument book. It's really important for the scrub tech to have the appropriate instrumentation ready and passed correctly so the surgeon does not have to look away from the field, especially if they're using the microscope. This particular slide shows you a variety of curettes, elevators, vertebral spreaders, and retractors. Your instrument book has a good selection of instrumentation that your text doesn't, so if you bring your instrument books to class, then we can talk about them together. I've got a few neuro instruments I'll bring to class for you to play with as well. It's customary for drills and perforators to be used during brain procedures, and burrs are often used on spinal procedures. They come with special attachments so the tissue can be protected while the item is in use. They may come in varying forms like battery-powered, pneumatic, or electric. It's our responsibility to make sure they're handled safely, that the tip of the drill remains cool so as not to harm the patient's delicate nervous tissues, and it's important to note that many of these devices have foot pedals, and you'll want to be cautious of them so as not to step on them during a procedure and activate the drill inadvertently. This slide shows the Rainy instrument, Rainy clips, and how they're used on a cranial procedure. The stainless steel instrument usually comes in your craniotomy tray sterile, but you need to open packages of Rainy clips to attach to the instrument. Then, when the incision is made in the scalp, which bleeds profusely, the clips are applied to control the bleeding instead of using cautery, which has the potential to affect the patient's ability to have minimal scar. Just think, if we cauterize that tissue to the point of hemostasis, there's a good chance the patient's hair wouldn't grow back in a pretty wide strip of scar tissue. We don't want that. Plus, I'm not kidding when I say it profusely bleeds. It would take a long time to control that kind of bleeding with just cautery. So instead, we use these clips, and they're passed rapidly, one right after the other. You'll likely have at least 2 in your set so that you're always loaded, and the entire incision will be covered in clips. In my experience, these clips were not counted, but that can be handled differently in other facilities. There are several types of implantable devices used in neurosurgery. It's our responsibility to handle these devices carefully to ensure the sterility and integrity. The FDA regulates the tracking of implanted devices in the event of a recall or unanticipated event like infection. All implants for all specialties must be identified via lot and serial number, date of manufacture, patient information, implant information, and physician information. On occasion, a previously implanted device will be removed during a procedure. Most explanted devices are sent for pathological examination before disposal. There's a fair amount of specialty sponges, drugs, drains, and suture used in neurosurgery. You've learned about cottonoid sponges back in the lab and how they're often used in ENT and neuro because they're small, gentle, and yet absorbent. Oftentimes, neurosurgeons will apply cottonoids or even radiopaque cotton balls to the neurotissue and then suction through them to avoid the suction tips from damaging the delicate nervous tissue. You'll see a fair amount of hemostatic agents used as well. There's topical thrombin, flow seal, and gel foam used regularly. It's very important to note that thrombin cannot be injected. It is topical only. Many surgeons use bone wax on bony edges because bones bleed quite a lot once they're cut. There's a lot of irrigation used, and oftentimes it has prophylactic antibiotics in it like Ansep or bacitracin. In my experience, the irrigation was usually refrigerated to ensure that the tissues would not be damaged, although room temperature solution can also be used. You would not want to ever use warmed fluids because they can easily burn the nervous tissue. You'll also hear the surgical team order osmotic diuretics for the patient, such as mannitol, to pull fluid out of the tissues, which reduces swelling. This is particularly important in brain surgery. Drains used during neurosurgery range from typical drains like Jackson Pratt's to specialty drains that can be inserted into the ventricles to drain excessive cerebrospinal fluid production. These specialty drains also have the ability to measure intracranial pressure, which is vital when patients have brain bleeds or trauma and they may be at risk for swelling. It's important that drains be implanted using strict aseptic technique, as we would not want the drain to be a conduit for bacteria straight into the nervous system. Most patients receive general anesthesia for brain and spinal procedures. However, there's always an exception. When receiving brain electrode placement, the patient will be lightly sedated so they can measure the electrical activity of the brain. Sometimes patients are left awake during cranial surgeries of areas of the cerebrum that could alter their ability to talk. Usually during cranial procedures, the surgeon has the patient turned in the room 90 degrees and stands at their head while the scrub is on whichever side anesthesia is not. For spinal procedures, many surgeons stand on the side of the patient that is most conducive to the use of their dominant hand. So it's going to be different for right and left-handed surgeons. However, some surgeons will stand on the opposite side of the patient's pain. So if they have pain shooting down their right leg, the surgeon will stand on their left. This enables the surgeon to really see into the right side of the spinal column when assessing nerve impingement. It's important for patients to be kept warm during their procedures, especially if we're using cooled fluids. Many of these procedures are lengthy, and normothermia is a real challenge. Also, a smooth emergence from anesthesia is important to reduce the risk of increasing their intracranial pressure and blood pressure. I showed you pictures of positioning equipment earlier, and it's very important for the surgical team to position the patient carefully. It's possible a patient may need to be placed in traction for their procedure. This allows the space between the vertebrae to be increased for their procedure. For cranial procedures that require the patient's hair to be removed, their hair is to be treated like a personal belonging, and it is not discarded, but rather returned to the patient after surgery. When the draping is complex, which is often in cranial surgery, it's important to allow the surgeon to direct and/or complete the draping themselves. Our final slide for this video is a quick review of Creutzfeldt-Jakob's disease. Remember, this is a disease caused by a prion that deteriorates the central nervous system. Should you be involved in a procedure with possible CJD, be aware that there will be very specific decontamination and sterilization processes involved, up to and including incineration of the supplies used. Each institution will have their own guidelines and policies. Never, ever flash autoclave materials that may be contaminated with this prion, as the cycle will not be sufficient in killing the prion. That's all I've got for you, so I will see you in class.